Good morning, friends. Our topic for today is total anomalous pulmonary venous. We will start with a case. Amrita, there is a lot of disturbance. Let us see this child, 15 days old, is weighing at birth. Amrita, I am not able to speak. There is a lot of disturbance.
Disturbance coming.
From where is it coming? Okay. Let's see this newborn who is a 15 days old child who is weighing 2.2 kgs. He has hardly gained any weight since birth. He has history of poor feeding and is irritable when he comes to your emergency room. On examination, you find this child who is cynosed and has nasal flaring and intercostal. The satisfactory and there is no murmur on clinical examination, but the child is tachycardic and tachypneic and has bilateral diffuse crepitations with 2 centimeter liver. The SO is loud and the split is appreciated. So now with this understanding, you try to do an ABG and you realize that the child is acidotic with normal PCO2. You give 100% oxygen with mechanical ventilation and realize that there is hardly any improvement in saturations. So this is a situation which is actually not very uncommon in a newborn setting. You do an X-ray and see that the heart looks like this and the lung fields, they look congested. The heart size is quite normal. So with this understanding, any one of you, what would you think when you are managing the newborn baby in the ICU? You have any thoughts? You can write in your chat box. It's a newborn baby, 2 weeks old with normal perfusion and no murmur, but cynosed, not improving with mechanical ventilation and has hepatomegaly with normal cardiac size. And the X-ray, the lung fields are not quite normal. So would you think of a respiratory cause? Are there any thoughts in your mind? Anybody? Can it be meconium aspiration? 2 weeks old child. Can it be a lower respiratory tract infection? Yes. All that can be there. However, we need to realize that there is this cyanosis and distress which is not responsive to oxygen, and also that the PCO2 was completely normal. The peripheral circulation is maintained and no murmur. So the question is, can it be a congenital heart disease? So remember, whenever you have this type of an X-ray, the heart size is normal, it still can be a cardiac disease. Especially TAPVCs which are obstructed, they tend to have heart size which is normal. And because it's obstructed, you have your lung fields which are congested. And this X-ray is very similar to an X-ray which you will get if the child has respiratory distress syndrome, meconium aspiration, etc. So remember to consider TAPVC as one of the differentials. If you have a child with cyanosis which is not responding to oxygen. So now we come down to the TAPVC. Now TAPVC, what is it? Total anomalous pulmonary venous connection means you have no connection of pulmonary veins with the left atrium. And because of some channel, they are connected to the right heart. It could be directly into the right atrium or indirectly into the right atrium. So finally, what is happening? You have a mixing of the deoxygenated blood and the oxygenated blood in the right atrium finally. So this is one situation where you have mixing of the pure and the impure blood, and hence the saturations are same in all four chambers because your mixing is happening at the level of RA, whether is it directly into RA or through IVC or SVC. But finally the right atrium receives both the sides blood. The incidence is not that common even in autopsy civils. The male-female ratio is equal. However, when the TAPVC is draining into the IVC system, that is somewhere below the diaphragm, then it is more found in males. Usually TAPVC is not associated with genetic issues, but they can have non-cardiac issues, and the typical ones which are associated with TAPVC is asplenia more than polysplenia. So they are isomonism syndromes, heterotaxy syndromes, when the baby has both the side organs like a right-sided organ. For example, the right lung and the left lung, both is like a right lung. Then commonly they can have associated asplenia and also TAPVC along with complex congenital heart disease. Most of the TAPVCs are in isolation and they do not have genetic inheritance. This is very peculiar when you counsel the parents when they plan for second child. It's important to reassure them that even if the first baby had a TAPVC, there are lots of chances the second and the subsequent pregnancies, babies could be normal. There's a little association with maternal lead exposure to TAPVC, but this is a little more theoretical. In practice, we do not find this correlation, and also that it's very difficult to find maternal lead exposure. So now with this understanding, remember that our today's talk is going to be not a very lengthy talk, but I want all of you to understand the pathophysiology. And because the pathophysiology will help you understand and pick up a TAPVC in a baby. So the whole emphasis is going to be on the fact that it helps you to suspect in a baby who comes without a diagnosis to you. Now, before we go to the pathophysiology, it's important for us to understand that TAPVC means you have connection of the pulmonary venous drainage into the right heart. So as I said, it could be directly into the right atrium. So you can see this figure where the pulmonary veins are connected to the right atrium on the back side, on the posterior side. So the pulmonary veins enter like this. This is the back of the right atrium. This is the tricuspid valve. This is the left atrium and the left ventricle. So there is nothing which enters the left atrium. You can see the left atrium is bald. The left atrium bald is a very typical sign as a pediatric cardiologist for us to diagnose TAPVC or suspect it on echo or even antenatal scans. So the pulmonary veins individually enter into the right atrium, and in the right atrium you already have the SVC and the IVC blood, so there is mixing into the right atrium. So from where is the left heart receiving blood? The left heart receives blood commonly through the foramen oval. So the foramen oval takes the impure and the pure blood, the mixed blood, into the left atrium, into the left ventricle and into the aorta. So what maintains the cardiac output is the AST. You can have associated ventricular defect or patent ductus arteriosus, which could also help maintaining the cardiac output. However, commonly it is the ASD, and most of the children in the newborn period, they have foramen oval. Now this foramen oval tends to become smaller as the child grows older, which typically happens by 4 to 8 weeks of delivery. So 4 to 8 weeks after life, this ASD can become restrictive and can cause obstruction to the cardiac output. There's another site of drainage into the right atrium, which can happen through the coronary sinus. Coronary sinus normally takes the coronary venous drainage into the RA. So normally it is very small because there is very little coronary venous blood. However, If this confluence gets connected to the coronary sinus, then it could enter into a coronary sinus which then becomes dilated and opens up into the right atrium. Now, this type of a TAPVC where the pulmonary veins commonly enter directly into the right atrium is unobstructed in the sense they do not tend to have obstruction. However, when it tends to enter into the coronary sinus, sometimes there could be narrowing at the mouth of confluence into the coronary sinus, which can cause obstruction. So you can realize here that if there is narrowing at this point, then I am going to have pulmonary venous obstruction indirectly, and I can have pulmonary venous congestion. Again, the ASD is the site where you have the mixed venous blood entering into the left heart. So these two types are called cardiac TAPVC. Either it enters directly into the right atrium or it enters into the coronary sinus. Now, as you can see here in this first figure, this is termed as supra-cardiac TAPVC. Supra-cardiac means it's above the level of right atrium. And the most common way of entering into a supracardiac area is where it enters into the innominate vein. So commonly we have this SVC which is on the right side. So we have this innominate vein which is on the left side. And the confluence tends to connect to the innominate vein through what we call it as a vertical vein. So this vertical vein takes the pulmonary venous drainage and enters into the innominate SVC and finally into the right atrium. Now remember that in contrast to the cardiac TAPVC, it has a long course, which is a venous channel. So during this course, sometimes it can develop obstruction. Now, if this vertical vein goes posterior to the left pulmonary artery, then it tends to be unobstructed. But sometimes this vertical vein can course between the left pulmonary artery and the left bronchus. And in that situation, it can get compressed between the LPA and the bronchus and have obstruction in its path. And this is typically termed as a VICE in the sense that there is obstruction to the pulmonary venous drainage, again producing back pressure changes into the pulmonary veins, and it can cause pulmonary venous obstruction. Supracardiac TAPVC accounts for approximately 40% of the total TAPVCs. That means it's a very common site of drainage. Sometimes it may not enter the innominate vein, but this vertical vein can be situated on the right side and enter the SVC directly, though this is less common. And sometimes it can enter into the azygous vein. Azygous vein usually enters the junction of SVC and innominate vein. So this confluence would then have a right ascending vertical vein into the azygous. And when it enters into the azygous vein, it tends to be obstructed at the point of entry into the azygous SVC junction. So this is about the supracardiac TAPVC. And then the last one is the infracardiac. The infracardiac TAPVC means it enters into an area which is below the diaphragm. It enters into an area which is below the diaphragm. Now, below the diaphragm means anywhere. It could enter into the portal vein, it could enter into the ductus venosus, it could enter into the hepatic veins. Now, most common is portal vein. So what happens? So this is the confluence, and then it has a channel which we term as descending vertical vein. Remember, here in supracardiac, this is the ascending vertical vein. So from the confluence, it goes up. Here, from the confluence, it goes down. So at a point, it crosses the diaphragm and goes below the diaphragm, enters the portal vein, and then enters the IVC into the right atrium. Infracardiac TAPVC is usually, let's say more than 90% of infracardiac TAPVCs are obstructed. Infracardiac TAPVC can enter the ductus venosus, but it's going to be difficult for us to predict that it specifically enters into ductus venosus. There is a little management difference when it enters into the ductus venosus. However, it's not a common portal of entry. 20% of the TAPVCs have infracardiac drainage. Remember that infracardiac TAPVC is usually obstructed and it presents very early in life. 80% of the infracardiac TAPVCs will die after 1 month if they are not treated, and 90% die within 2 months. So within 2 months, 90% of the infracardiac TAPVCs die because they are obstructed in their circuit. The obstruction could be at multiple points. It could be at the level of portal vein, ductus venosus, diaphragm, etc. Same happens with supracardiac when it's obstructed. So infracardiac and part of supracardiac, they tend to present much early in life just because they have more tendency to be obstructed. Now, there are TAPVCs which can have 2 sites of drainage. That means more than 1 site of drainage. That is termed as a mixed TAPVC. And the most common in mixed TAPVC is a combination of the first and the second figure. That means you can have 3 veins draining into the coronary sinus and you have 1 vein draining into the innominate. Commonly, you have the left upper draining into the innominate and the right sided and left lower draining into the coronary sinus into the RA. And this is very important for us to understand so that we can convey this to the surgeon and they do not miss 1 or 2 pulmonary veins draining somewhere. That is called a mixed TAPVC. Very rarely you can have the same confluence having all 4 veins draining into supra and infra together or supra and cardiac together, and that is termed as a dual drainage. The same confluence has 2 sites of drainage is called dual drainage. When you use the word mixed TAPVC, that means you are telling that it has cardiac and supracardiac, but you do not have a single confluence draining into 2 sites. Now with this understanding, we will go into the pathophysiology, and pathophysiology is the most important part of understanding in a TAPVC because it has clinical implications. The timing of presentation, the type of symptoms are different based on the type of TAPVC. So let's see this. This figure shows you a supracardiac TAPVC. So you can see here I have the SVC and the IVC going into the right atrium. My pulmonary veins are not connected to the left atrium. So the left atrium is bald and I have a confluence which is not opened up into the left atrium. Remember, embryologically, the pulmonary veins, they normally form a confluence and slowly get resorbed into the left atrium. You have the resorption of this confluence into the left atrium. If it does not get resorbed, you have a separate confluence which has the individual pulmonary veins. Now, this confluence is actually a space between the left atrium and the descending aorta. So whenever you find a lot of space between the descending aorta and the left atrium, even antenatally we use this sign to suspect TAPVC. Remember that during pregnancy, it's only 10% of the cardiac output which enters into the pulmonary veins. So it is going to be very little pulmonary venous written. So to pick up TAPVC in pregnancy is difficult and it's crucial also because you don't want the baby to be undiagnosed when the baby is delivered. So there are 2 signs during pregnancy which we use. One is that the left atrium appears bald, and second is the distance between the descending aorta and the left atrium is more. So you have a separate chamber between the descending aorta and the left atrium. So what is happening here? The pulmonary veins are draining into the confluence and then they are connected to the vertical vein. See here, the vertical vein is between the left pulmonary artery and the bronchus. And then you have the left ascending vertical vein, which then enters the left innominate vein and it then enters into the superior vena cava. So you have a mixed venous blood into the right atrium. And then this mixed venous blood is entering into the right ventricle and it is going into the pulmonary artery. And then through the ASD, it is also going into the left atrium, into the left ventricle, into the aorta. So you have the same saturations, for example, 80% RA, 80% RV, 80% LA, 80% LV, 80% PA, 80% aorta. So this is one cardiac disease. There is hardly anything else in cardiology which will have the same saturations in all the chambers, all the arteries. So that is TAPVC. So let us see what are the peculiarities of TAPVC. One is that there is complete mixing in the right atrium. Second is that you have an obligatory shunt across the ASD, which is right to left. There are very few heart diseases where you have an ASD right to left. TAPVC is one such important disease. And third is you have a long circuit for pulmonary venous return. This long circuit is important because in that circuit, it can have obstruction. I hope this is clear. Anybody has any questions, please feel free to chat in the chat box. If it goes without understanding, then slowly as the next slide comes, it might be difficult. Any questions, anybody? Okay, so now with these three understandings, we go to the next slide. So remember in a TAPVC, you have flow from the right atrium to the right ventricle and also right atrium to the left atrium, right? So it's from right ventricle and also left atrium, RA to RV also and RA to LA to LV. This is going to add to the pulmonary venous, pulmonary arterial blood flow, and this is going to add to the aortic flow. So now the question comes, what decides how much flow will enter the RV and how much flow will enter into LA and LV? So obviously, you have the ASD size, which decides how much blood will enter from RA to LALV. If my ASD is big, then it allows more flow. And if my ASD is small, then I have a relatively less flow and my cardiac output could be affected. Is there anything else which also decides the amount of flow? And that is the resistance. The balance between the resistance in the pulmonary circuit and the systemic circuit. If I have my pulmonary vascular resistance low, then I'm going to have a lot of flow entering the right heart. And if I have my pulmonary vascular resistance high, then my amount of flow into the pulmonary circuit is going to be resisted. So my PVR is another factor. So finally, the ASD and the pulmonary vascular resistance decides how much my mixed venous blood flow will go into the right ventricle and into the left ventricle. As the neonates grow, the ASD tends to become small, restrictive, and my pulmonary vascular resistance falls. If my ASD becomes restrictive, I have less flow entering the left heart. And if my pulmonary vascular resistance falls, I have torrential flow entering into the pulmonary circuit. What is there in a newborn on day one? Pulmonary vascular resistance is high. So it does not allow a lot of flow entering into the lungs. I hope this is clear. Now we go to the understanding that. Remember, the right heart is something which is involved in a TAPVC because I have mixed blood. All the systemic and pulmonary venous return in my right heart tends to be much bigger. Now coming down to the individual 3 scenarios in a TAPVC. Either I can have obstruction in the circuit, as you can see here in this figure. I have obstruction in the vertical vein, or I can have restriction at the level of ASD, or I have no obstruction in the circuit and no restriction in the ASD. Remember that the presentation of the TAPVC depends on whether you are here in the first figure, whether you are here in the second, or you are here in the third. And your presentation can vary. You can have a TAPVC which presents on day 1, and you can have a TAPVC which presents at 5 years of age if you are here in the third figure. And hence, only your index of suspicion is going to pick up a child with TAPVC. So now let's see what happens when you have obstruction in the circuit. So if you have obstruction here in the vertical vein, then what happens? You have this pulmonary venous drainage not being able to enter the SVC very smoothly. So you have back pressure effect into the pulmonary veins, and hence you have pulmonary venous congestion. Because of pulmonary venous congestion, you have hypoxia and acidosis. Your ASD is unrestricted. Your ASD is taking all the blood into the left heart. So there is unrestricted right to left flow into the aorta, and your cardiac output is maintained. The child which came to our NICU initially, as we saw as a case, was hypoxic, was acidotic, but the cardiac output was maintained. And also because my pulmonary venous circuit is obstructed, I do not have a lot of flow into the pulmonary circuit because my pulmonary vascular resistance is high. And that's why my heart size is maintained. So on X-ray, I have no cardiomegaly, I have no murmur clinically, my perfusion is maintained, and I still have an obstructed TAPVC. The clue was desaturation, pulmonary edema, crepitations, and acidosis. So these babies tend to present very early with respiratory distress, grunting, tachypnea, and desaturation. The number of hours which keeps adding to this, if we don't pick it up, then the child tends to become more and more sicker, and the pulmonary venous congestion becomes more and more bad. You can see the reticular pattern on X-ray worsening to an extent that you will have complete whiteout in X-ray. And also remember that when you have obstruction in the circuit, earlier surgery is going to have better outcomes because slowly the lungs will become stiffer and stiffer, and your surgical risks will become more and more. Your lungs become very stiff during surgery, they trouble during bypass, and also after surgery, the recovery, the lung related recovery takes longer, and they tend to resolve their pulmonary arterial hypertension after long days. So this is the first situation. This presents in the NICU. The second type of presentation where you have restriction in the interatrial communication. That means the ASD becomes restricted. Normally the foramen oval tends to close as the child increases in age. And in that situation, this typically happens at 4 to 6 to 8 weeks of life. And what happens here? See that your systemic venous return is here. Your pulmonary venous return is unobstructed, which also enters into the right heart. So now my right heart has a lot of blood. It can easily enter into the RA, RV and the pulmonary circuit because by now my pulmonary vascular resistance has fallen. But the second way of outlet is small. So there are two things which are happening here. I have reduced flow entering the left heart and reduced cardiac output. And second thing is I have a lot of flow into the right heart and a lot of pulmonary blood flow. So my saturations are maintained, but I have increased pulmonary blood flow. So I can have failure because of increased pulmonary blood flow. So my baby is going to be presenting few weeks later in failure, but not much of desaturation. If this situation continues for a longer time, then I am going to have a lot of pulmonary blood flow, because of which then I can tend to have complications because of increased pulmonary blood flow. Most of these babies tend to be less flu but in low cardiac output. Typically, they have significant systemic venous congestion. So clinically, you might find this baby saturating 85 but having pulsatile liver, and the pulse volume will not be normal. So now this is a second way of presentation for a TAPVC. Now this is third, where you have ASD unrestricted and the pulmonary venous circuit also unrestricted. So these babies have mixed blood going into the lungs and also going into the body. My saturations could be 90%. I will have increased pulmonary blood flow, so I'll have some failure. So these babies present very similar to an acyanotic heart disease because 90% saturations you may not be able to pick up clinically. And these babies tend to present a little later in their life with failure. But if you see them carefully, you will find them dusky and sometimes clubbed after 6 months of age. Now these babies present by 3 months, 6 months, and sometimes even later in life. You might see a TAPVC even older than 5 years of age. They will present like an ASD because what they have is primarily an ASD with a mixed circuit. And if you check their saturations, you'll realize that they're not saturating fully. And after 6 months to 1 year of age, you might appreciate clubbing. Clubbing, remember that it's related more to chronic cyanosis and not degree of desaturation. So if you have chronic cyanosis, saturations of 85, 90, then you will still develop clubbing after 6 months to 1 year of age. These TAPVCs tend to develop pulmonary arterial hypertension after 6 months of age related to increased pulmonary blood flow. And till a particular age, they have hyperkinetic pulmonary arterial hypertension. That means the lungs do not have a damage, but after some time, they may develop obstructive changes in the pulmonary circuit, causing irreversible pulmonary arterial hypertension. So even this situation is not safe to continue for lots of years. And hence, what is important? To pick them up. To pick them up is in your hands. So it's very important to take this message today that even if you're sitting in the OPD practice, and if a child sounds like an ASD means what? We will see in the next slide. How their typical clinical presentation is on examination. What are the examination findings? So it's very, very important to appreciate the clinical findings of an ASD and then see if the child is not saturating fully, is to suspect TAPVC in OPD practice. So now, with this understanding, let's see. Now I'm going to make you hear a normal second heart sound. Listen to this. I'm not sure how nicely it will be audible, but now let's see what happens in a TAP. So what happens in a TBVC is, apart from cyanosis, you have a systolic murmur. So it's an early ejection systolic murmur which starts with S1 and it does not reach the S2, and this is because of increased pulmonary blood flow. And apart from that, your second heart sound is wide, fixed, split like an ASD. I'm going to play it once again so that your ears get used to this. See that second heart sound. See, in children, because of tachycardia, it gets very difficult to appreciate this split. and also the second heart sound is normally loud in a newborn. So it's very difficult to suspect TAPVC in a younger age group. But if you can appreciate this split, that is rewarding. And now see this figure. You have the heart size which is normal, and this happens in an obstructed TAPVC. If it's unobstructed, then your heart is going to be big. You're going to have right atrium and right ventricular dilatation. Your lung fields will be depending on whether you have pulmonary venous obstruction, like in this figure, or you have increased pulmonary arterial blood flow, where you have plethoric lungs, like a VSD. So remember to see the heart size, remember to see the lung fields. And on ECG, you will have significant RVH. For a newborn, you have significant RVH and right axis deviation. So these are the ECG findings. Whenever in doubt, at least what is possible at your level would be a hyperoxia test, X-ray, ECG, and clinical examination in terms of understanding the second heart sound. The second heart sound is the crux for a clinical diagnosis of PVC. Okay. Now, echocardiogram, if it is possible, and if any one of you is comfortable using the probe, remember that to suspect TAPVC, always go from the subcostals. I am not going to go into the echocardiography detail in today's class. However, this one clipping I have kept because if you are comfortable doing even a basic echo, see if you can have this understanding. Subcostals, you put the probe in the subcostal view, and you will see this, that my left atrium is completely bald. So my left atrium is not receiving any venous drainage, and I have this confluence between the descending aorta and left atrium. And in this particular situation, my confluence is entering into the, see this left atrium, my confluence is entering into the IVC. So if I can trace a flow which is going into the IVC, then that is going to be a super diagnosis bedside. And I know I need to act immediately and not sit on it with just respiratory support and antibiotics. So something like this you will see below the diaphragm. If you see a flow entering the IVC and then entering the right atrium, then it's an TAPVC which is obstructed, infra-cardiac, and the next thing we need to do is to do something with TAPVC. So what do I do when I suspect TAPVC as a pediatrician? I need to stabilize the child. Now, how do I stabilize? Whatever I had to do, I did in terms of mechanical ventilation and respiratory support. But that is not going to make a lot of difference to the child because of pulmonary venous obstruction. Can I consider prostaglandins? Now, if I am suspecting TAPVC, remember that the only way out is early intervention. The number of days I spend without surgery, the child is going to become sicker and the risks of surgery are going to be more. Once I operate, this baby can have a normal life. I would say 95% of these babies tend to have a normal life. And so very, very important to suspect, very, very important to counsel the parents and push them for surgery. And surgical intervention is the only way out. During surgery, the risk of surgery basically depends upon the number of days I have spent without operating. That means my lungs stiffness is going to be depending on that, my PA pressures, and my size of the pulmonary veins and the confluence. So long term, if my pulmonary veins are good size and does not get restenosed, then my baby is going to have a normal life. Can I consider prostaglandins while shifting? So this is the question, and it's actually very controversial because if I open up my PDA with prostaglandins in a newborn, I could be opening the PDA, adding to more pulmonary blood flow in a circuit which is obstructed. Then my child is going to be more distressed. However, there is a little point here. If my TAPVC is infra-cardiac and it enters into ductus venosus, which is closed, and if I open it up, then it could allow for decompression. Even sometimes my PDA could take the blood from the pulmonary circuit to the systemic circuit, then also it could decompress my pulmonary circuit. So I would say that if you have a child who is cyanosed, not responding to oxygen, and you're planning to transfer, it's okay to consider prostaglandins and see how the baby behaves. If the baby does not become worse, you continue prostaglandins till you finalize your diagnosis and management. But remember that TAPVC diagnosis, the crucial point is it lies into the hands of the pediatricians. That's all of you. And also, timely transfer of the child could make wonders in the life of the baby. Thank you so much. We are ending our talk today. Any questions, please feel free to ask questions. I would be happy if you have some questions so that it makes me feel that you understood the lecture to some extent.
Any questions?
Ma'am, please check the chat box, ma'am.
Chat box?
Yeah, from GSC Kollam.
Oh, okay. I got it. I got it. How high can be the saturations in unobstructed TPVC? Yes, it's a very good question. The saturations usually will be in the range of 90%. Unobstructed TPVC actually should saturate more than 85% if they have not developed obstructive damage to the lungs. So unobstructed TPVC, which is clearly operable, should saturate more than 85%, around 90%. In a newborn unobstructed TPVC, they could range between 90 to 95%.
Ma'am, there is one more question.
Yeah, okay, I get it. How do you identify pulmonary veins on echo? Okay, so pulmonary veins, I understand that your question is probably related to TAPVC or in general. So we will start with normal heart. In a normal heart, we can see the pulmonary veins on 2D, just as we see that they are like pulled ears into the left atrium. So the left atrium structure is normally like pulled ears. You see this on 2D entering into the left atrium. Then when you put color, you can see the venous type of a drainage, the venous flow entering into the left atrium, and you can actually Doppler and make sure that they are pulmonary veins. Now, if I see the left atrium bald, then I try to see for a confluence behind the left atrium. So I can then trace the individual pulmonary veins, like normally how I see pulmonary veins on color and Doppler, and they enter into the confluence. Once I demonstrate the confluence, I will always screen the rest of the venous structures like innominate vein, SVC, to see if I have additional one or two veins entering separately. So that's how I would see the pulmonary veins. Do you use the short parasternal axis only or suprasternal view? So I diagnosed my TBVC in subcostals. So that is very interesting. By the time I will leave my subcostals, I have a diagnosis of TAPVC, and most of the times I know where is it draining. From subcostals, you can figure out everything. I see my left atrium bald, I see a confluence behind the left atrium, and I see a ascending or a descending vertical vein. So I'm fairly sure that I have a supra or infra. And if it's entering into the cardiac TBVC, I can see a coronary sinus in subcostal. So remember that you have your diagnosis made in 90% of cases in subcostals. Further fine-tuning to see individual veins, definitely I will use the other views, including apical, short axis, parasternal, long, and also suprasternals. The next question is, can shock be a clinical presentation in obstructed TAPVC? So remember that if I have an obstructed TAPVC in the circuit, usually my perfusion is maintained. I will not have a child with shock unless and until I have severe ventricular dysfunction related to hypoxia. But on the other side, if I have my circuit which is obstructed at the ASD level, yes, then I can have a child presenting a shock. I hope the explanation cleared your doubts. I am very happy that you have that thought process. Any more questions?
Madam, we have a question.
Does ABG have a role in TAPVC, that is less than 85 saturation, etc.? Is there ABG? Does
So
it have a role?
you are talking about in an ICU situation, or you're talking about later in life, OPD practice?
NICs.
NICU, yes. For you to suspect, you will need an ABG because you need to know your partial pressure of oxygen, PaCO2, and your response to oxygen or mechanical ventilation. So in that, your ABG will help you. But I would say that your baseline ABG and response to oxygen on saturation pulse oximeter can also give you a clue. But a baseline ABG, yes, definitely, to see the involvement of pulmonary circuit. Say, for example, you have mecanum aspiration, sometimes respiratory distress, lung-related issues, you might be a little more clearer with your ABG.
Thank you.
Any
Okay,
more
so
questions?
questions?
Madam, go.
Any more questions or clarifications? Government Medical College, Manjeri, do you have any questions?
Okay, I think Amrita, there are no questions. Should we end our session today?
Yeah, yes, ma'am.
Yeah. Okay. Thank you so much. Thanks, Amrita. Thanks, everybody. Have a lovely day.
Thank you, Dr. Sejal, for your wonderful presentation, and thank you all for joining.